Hello, everyone. Welcome to Healthy Retailer's first webinar on the topic of employer-sponsored pharmacy benefits. I understand we have we probably have a pretty nice group of employee benefits consultants on the line, and we've also got a few folks that are friends and supporters. And I'm just gonna click on you, Jeff Lundgren, if you don't mind. I'm just gonna have Leanne say hello to you. Jeff, are you on the line?
Yep, I'm here.
Great. So we wanted to make sure we said hello and then introduce you guys. I think I introduced you guys over LinkedIn, but my team is on the line. You see their pictures and their descriptions. That would be Rick Hans, formerly of Fred's Pharmacy in the Southeast. My co-founder, Isabella Spiegel, formerly the Vice President of Benefits at Ascena Retail, which is Ann Taylor and Dress Barn and other brands. And then our friend, Dr. Maya Heinert, who's a former ER physician and has lots of stuff going on in the broader topic of community health and is learning lots about employer-sponsored healthcare. And so we welcome her. Those three folks will be asking some questions at the end that we think that will be beneficial to the entire group. So without, I'll hand it over now to Dr. Leanne C. Boyd, the founder and CEO of Southern Scripts.
Well, thank you very much, and good afternoon, and appreciate Joe and Jeff, you all having me and allowing me to talk about PBMs and pharmacy benefits. And it absolutely is something that I could spend hours talking about, but we will squeeze in a lot of information in 30 minutes, and I hope the group on the line will find the information informative and certainly welcome questions towards the end. So we'll just dive right in with that. Many of you may be familiar with what a PBM stands for. For those that are not, it's simply defined as a pharmacy benefit manager. And the wheel on the screen is showing how all the various components come together for a self-funded health plan. And that's the space that I've spent most of my career in serving as self-funded payers. And so from the stop-loss agent to the TBA and so forth, those come together to offer this comprehensive healthcare program to the employees of the payer. The PBM certainly is the part of the wheel that is handling some basic functions, and I've listed them here, from adjudicating claims and establishing pharmacy access for members to fill prescriptions and providing customer service or reporting and so forth. And so on the sense of the very basic level of what a PBM does to take care and play the role of the PBM, all are fairly created equally in the services that they provide. The next slide goes into asking the question, why are employers, and starting to answer, why are employers becoming more and more focused on what is going on in the PBM space? As the PBMs and as pharmacy has been evolving, payers are seeing how pharmacy benefits and pharmacy drugs, especially specialty drugs, are the key drivers behind rising healthcare costs. When I started in the PBM space, if you look at the aggregated spend for an employer, less than 20% was typically pharmacy spend, with 80% on the medical side. That is shifting, and we're seeing employers shifting to closer to 30%, even some closer to 50% of their total dollars that are spent to cover the health of their employees is growing on the pharmacy side. Um, it is also one of the top 3 most expensive essential health benefits, which further creates the need for health plans to cover these and offer these to their employers. And it is very complex, and it is a complex far side of the business. The way claims are even managed and paid are complex and real time. And so it is a very important growing piece of this circle into the overall landscape of a self-funded payer's plan for their employees. I often get the question, well, I don't even know who a PBM is, because most of the time the PBM is sitting in the background. The top 3 PBMs represented on this slide, Express Scripts, CVS, Health, and Optum, they, depending on what source you look at, represent between 70 to 80% of the market. They're known as the traditional PBMs. They're known as the big 3 PBMs. And then filling out the remainder of the PBM market are mid-tier PBMs, and you can see them listed here, such as Prime and MedImpact. And then there are smaller, more boutique PBMs that make up the remainder. Certainly, I serve as CEO of Southern Scripts, and we fall in that realm of a smaller, more unique PBM. One of the key questions that I hope to help enlighten and during this time is to get you to think about how PBM and payers are aligned. And I think a lot of that is we're going to spend around the revenue model of PBMs and educate some things that happen, and really help you educate, give some tips about what to ask for, what to look for, to better ensure that the PBM and the payer is aligned. There is a quote on your screen about how relatively few employers believe the goals of their PBMs align with the goals of managing their employee health. And that is taken from a very good study that was done. It's not too old, maybe a year-ish. It's called Towards Better Value, and certainly would encourage anyone interested in the space to reading that. And it's asking employers how they feel about PBMs, what values and services they prioritize and feel are important. And it has some very unique and eye-opening results as to how employers feel and think about what's going on in the space. So that would be some really good homework if anyone needs some reading material for tonight. So with that being said, we'll jump into some of the meat. I characterize PBMs into different models. And the models is simply around the revenue model. The most common model, again, 70-80% of the market, is going to be in a traditional PBM model. There's lots of different revenue streams, and none particularly have to be disclosed to a client. Then there are terms that have been used called transparent and pass-through. And I certainly want to make an impression on everyone that transparency and pass-through, although they go together, they do not mean the exact same thing. So transparency is about being disclosing the various revenue sources, giving insight so that employer can see that and see whether or not the revenue model is in line with what is in the best interest of the client. They're disclosed. Whereas pass-through means very specifically that the PBM's revenue model is the cost of the drug or pass-through dollar for dollar from the pharmacy to the client. Rebates are pass-through dollar for dollar, penny for penny to the client. And the PBM simply is charging an administration fee. And those fees are straight to the client and fully disclosed, and they're not fees on the backside being charged and paid by the pharmacy and so forth. So, and then you can see a combination of aspects of a PBM being more traditional and being more pass-through. For example, you can see retail claims being ran through a pass-through type scenario, but yet when you get to the specialty side of the equation, those are being administered in a more of a traditional format. So you can have a hybrid as well. So traditional, transparent, pass-through, and hybrid PBM models. I included this because I think it underscores why this webinar is important, as well as how the market is really calling for and looking for transparent solutions. I think they recognize the significant cost factor that is happening through the pharmacy side, and feel that the lack of transparency is a cause to some of the reasons why the cost continues to be rising and is less contained. So a day doesn't go by that I don't think you can find an article about PBM and transparency in the news. So jumping into how PBMs make money, go back one. To simplify it, we have here 5 key revenue buckets: drug pricing, rebates, mail order, specialty, and fees. In each one of these revenue buckets, a PBM may be generating revenue on a specific client in one or all of these buckets. In a traditional model, you can see that we call them levers. These are the various levers, and they have the ability, a PBM can, if they're generating more revenue off of a generic drug pricing, then they can generate less revenue off of a brand drug. And then with rebates, if a client is really geared and focused on rebates, they can increase the rebate dollars back to the client, lowering their revenue, but then they can make up that in specialty drugs and so forth. So the ability to move these levers back and forth to generate the particular revenue that is needed on a particular case. Sometimes it's the squeezing the balloon. I've heard it referenced as whack-a-mole, where you try to fix something on your rebate arrangement, but yet the cost maybe pops up in your brand drug pricing. So it's constantly having to look and monitor to how each one of these buckets are being treated by the PBM to ensure you're able to negotiate and monitor for the best pricing possible. And in the end, it shouldn't be about one, but it should be about factoring all of these things together and figuring out what is the bottom line net cost to the plan, and what avenue do you need to go to ensure that you get to that best, lowest cost. And to simplify things, the pass-through model eliminates all the variables and simply charges an admin fee. So an admin fee is traditionally going to be much higher than in a traditional model because all the revenue and the PBM will rep and warrant that that's the sole revenue source. This slide is a little bit of good Southern drama for you, but it does illustrate that from my simplified 5 buckets, there are many more buckets and ways underneath those that contribute to how PBMs generate revenue. Revenue that may or may not be fully disclosed or transparent to the client. We'll focus on a few things today, and certainly look forward to generating further discussion. And this is in no way meant to be exhaustive, or does it imply that every PBM practices in this way. These are common ways that I've seen through my various years in the industry. So to start, and the most common based on drug pricing is spread. And I'm sure if you've been working in the PBM industry or in health benefits, this is very common. This isn't as unknown as other practices, but essentially it's where the PBM pays the pharmacy one price and then will charge the employer a different price, creating a markup or spread in between. In this particular example, I've highlighted for you how the PBM, through their negotiated discount with the pharmacy, receives a payment of $164. The employer then receives a bill from the PBM from $170. And in this particular example, the PBM revenue on the script is $6. Certainly, spreads and markups are common in various businesses. I think one of the differences here is they can vary widely in the spread, and it does create that black box of not knowing what is this true dollar amount that allows you to assess for the services provided, is this a fair and reasonable rate I should be paying? The bottom chart is a snippet out of a Ohio Medicaid auditor report. I thought it was interesting that when you start aggregating the spread, in this particular case, of the prescriptions filled, it ended up to $224.25 million in additional costs due to spread. So spread is a common revenue form for PBMs, and again, it's when the pharmacy is paid one price and the employer is then billed a different price. Next is something that's called drug switches. So most drugs out there, or all drugs, are assigned what's called an NDC, or National Drug Code. And I kind of make it similar to a Social Security number of a drug. And the NDC of the drug is attached to something called AWP, which stands for average wholesale price. And just think of it as a list price. So this drug is assigned a specific list price. And then how PBMs contract pharmacies are traditionally, again, through these discounts. And so in this particular example, the pharmacy is paid off of a specific NDC. And that NDC had a list price of $100, a discount of 70%. The pharmacy was paid $30. One of the tricks that I've observed is that a PBM will then bill an employer using a completely different NDC than the actual pharmacy was paid on. And many times, when they're picking a different NDC, they will traditionally pick an NDC with a higher list price. So if you walk it over here, the PBM then ends up billing the employer using the higher list price, in this example, $175, a discount of 70%, left the bill to the employer for $52.50. So now our spread, our markup, has increased from the $6 in the previous slide to the $22.50 because the PBM switched the NDCs, billing at a higher price. And this further shows an example of a generic drug. And generic drugs commonly have multiple different suppliers of that medication, and each one of those are going to have a different NDC. And you can see the list price here varies quite substantially. This is per tab, and it can vary here in this example from $185 all the way up to $394. Makes quite a big difference in the list price, and then that list price is the basis for any discounts to be applied. So definitely have to look further than just the discounts, and a thing to look for with the PBM is ensuring that they're billing on the exact full 11-digit NDC of the drug that actually was dispensed by the pharmacy at the data service. So you want to protect against any NDC switches. Next is something called reclassification, and where this is the pharmacy is paid for a generic drug, and a generic discount is going to be much more substantial than a brand. In this example, the discount is 70%. So our pharmacy is paid $30. However, due to creative definitioning in a contract between the PBM and the employer, many times the PBM is able to reclassify that same claim as a brand and apply the brand discount, in this example 15%, and results in billing the PBM sending the bill to the employer for $85. Again, a difference of $55, allowing them to increase the spread. So being certain as to what the specific definitions are laid out in the contract to ensure that is not left up into interpretation. There is also a tactic called ZBDs, which stands for zero balance due. And there are many times when a member goes to the pharmacy to get a prescription and the cost of the drug is below the member, it can be satisfied completely by the patient's copay, leaving no cost to the employer to pay. And many times PBMs will market themselves based on discounts that they can provide. And I think I've already shown how discounts can be manipulated, but this is another way in which a discount can be overinflated because a PBM will count these claims as 100% discount since they paid zero and the member paid the full cost of the drug versus truly representing what the pharmacy was paid at a 70% discount. That allows a little fluff in the system, so when they need a few extra percentage points, that falls in the favor of their discounts that they're trying to guarantee. Very similarly, there is something called clawbacks. It's also a very common thing that you can Google and read all sorts of stories about clawbacks. But in the end, it's very similar in that the patient pays the full cost of the drug through their copay. So in this particular example, based on the contract with the pharmacy is owed $30. So the PBM agrees to pay the pharmacy the $30. But the member's copay is set above the $30, in this example, $75. And the pharmacy is required to collect the $75 copay, meaning there's a differential of $45. And the PBM will claw back that $45 from the pharmacy and capture that as revenue. So again, the pharmacy's paid $30. The member has to pay their full copay of $75, even though the drug did not cost the $75. And the difference, the pharmacy owes that back to the PBM. Switching over to talk about mail order for just a minute. Certainly, mail order can be a convenient option, and it can be a good pharmacy provider for members for various reasons. However, so I don't have a opposition to mail order in general. However, mail order has traditionally been known as the crown jewel of the PBM. It's shifting more to specialty these days, but there's a lot of cost. And then time and time again, I've seen and observed where members, these stockpiles of medications, generating a great deal of waste in the system and very expensive medications. And I feel that there's some less safeguarding against these practices sometimes in the mail order space. But mail order does serve as a very strong component of a traditional PBM space. These are mail orders owned by PBM. First of all, things to think about is steerage. Many times a mail order will offer a preferred deal to a client and encourage them to waive and mandate mail order. Many clients do not realize they believe that copay is waived and absorbed by the mail order, where the waived copay is really actually absorbed by the plan. So you have a 90-day supply of medications. Normally that would be 3 copays. You waive 1 copay for the member. They only have to pay 2. Where does the third one go? Who pays it? And the answer to that is traditionally going to be paid by the client. The hopes that the discounts would add up and be a better value, but I would question if that's really the case in many situations. So watch for waiving copays. Also, there's something that we call refill creep. Mail order pharmacies will auto ship lots of medications to the member, creating those pictures that we saw above that were published by NCPA. Many times a mail order PBM has a refill handler that is lower than a traditional retail pharmacy. In my specific case listed here, I've seen typically refill handlers of 70%, meaning that the mail order can go ahead and automatically ship a new 90-day supply once 70% of the supply has been consumed. Most retail pharmacies, that's going to be closer to 80%. And what happens, this ends up creating an extra 1 to 2 fills per year. And remember, these are traditionally 90-day fills, so it can be very expensive for a plan if they're picking up 1 to 2 extra fills per year. In the bottom left-hand corner, there's something called package size, where the mail order will bill for a size of 100, but the most common quantity that is dispensed in a mail order facility is 90, meaning that it allows a PBM to bill for 100 even though 90 were only dispensed. So 10 never went out the door, but yet the employer gets billed. And then lastly, with mail order, there's something called repackaging, where the mail order is allowed to assign its own NDC. Remember, that's the Social Security number of the drug, and then gets to assign with that the AWP or the list price, and many times that repackaged NDC is going to bear a higher list price. And then just to kind of round out our discussion, a few comments on rebates. That is a large area of dollars in this pharmacy system. And there are a lot of opportunities for rebates to have tactics deployed around that. Specifically, I'm showing here that it's the opposite of what we talked about earlier, where the brand drug gets filled and paid, but yet when we go to look at the rebates on that, they end up deeming that drug as a generic and steering. Many times they'll prefer a brand version of a drug over a generic with the goal of netting that rebate. And then on rebates, cherry picking involves where a client may receive rebates on brand at retail, but not rebates on specialty drugs, or specialty drugs you're only going to receive a rebate at a particular specialty pharmacy, not on all your specialty claims. And this kind of illustrates the significant dollars behind rebates and how rebates can be bucketed into different terminology so that the rebates don't flow back to the employer. In this particular example, it shows how there's a formulary rebate, an admin fee, and a price protection rebate. All are manufacturer dollars, which I would propose is the better term than rebate. But this dollar amount was classified as the rebate and was the portion shared back to the client, which was only about 7% of the total manufacturer dollars that flowed back to the PBM from the manufacturer. And lastly, this little slide chart here shows the differences between an insulin price, and the bottom line is the price where the manufacturer receives. The top price is that price that gets paid. And the question is, what happens to this pot of money between the two? And that typically would be assumed to be rebate dollars paid back into the system. So that is covering a lot in 30 minutes. And so I certainly want to just take a minute to introduce Southern Scripts. We are a PBM that is pass-through on both pricing and rebates. We bundle all our services into an admin fee. We don't do a lot of upcharging, and we will we do rep and warrant that that is our only revenue source. And we try to go beyond just discounts and rebates and really help a client find long-term strategies to managing their drug cost. So hopefully that was some great information for you all to think about. It's pretty heavy information for mid to late afternoon, but certainly if there are questions, I'll be glad to spend a few minutes to answer those for those that have a few extra minutes to stay on the line.
Wow. Thanks, Doc. Thank you, Leanne. So I'm going to, at this point, just make mention of kind of why we're here with Healthy Retailers, because the three folks that you're going to hear ask questions now are, one is my co-founder, Isabella Spiegel. She was, as you see in the announcement, she was the VP of Benefits for a senior retail, or Ann Taylor, for 20 years. And I contacted her after she retired, and we started chatting and decided we wanted to collaborate and kind of bring some focus to the fact that retailers as employers and retail employees, if you look across the industry, are probably two groups that are least able to sustain the kind of lack of transparency that Leanne has just given us an introduction to. So, and then also a gentleman that we were very pleased to meet a couple months ago, who spent 20 years at Walgreens and retired as the CFO, Chief Financial Officer of Fred's Pharmacy, a chain that was once in the Southeast. And our friend Dr. Maya Heinert is a former ER physician. I'm going to let each one of them talk, and I'm going to start with Rick. And I think Rick probably has a comment, and I'm going to put him on the spot and ask him to kind of make a comment responding to what he's just heard. And Rick, you can take a minute to kind of give us an introduction of where you came from and why you responded to the invitation to collaborate with us. And then if you have a question for Leanne, I'd encourage you to ask. And Isabella, you're up next. So.
Yeah, thanks, Joe.
Sure.
And first of all, I just want to say I think the presentation really hit the nail on the head. I'm probably on record. I spent 16 years really doing investor relations at Walgreens, so I've had my share of run-ins with the PBM model and having to, talk to analysts about our challenges dealing with the big PBMs. And of course, we had a pretty well-known and public dispute with Express Scripts back in the day. And really, my problem with it all along has been that they make abnormal returns because they have so many vehicles that they've invented, as a middleman to take money out of the healthcare system. And, it's gotten probably even worse now. They've all become parts of bigger healthcare models and probably able to hide their profitability even more. So I've been someone who's questioned the PBM model my whole life. I think it's very insidious, almost parasitic to the healthcare system. And I would just challenge anyone, is it really fair, that a drugstore buys a drug, warehouses it, ships it to thousands of different stores, fills it, customers talk to the pharmacist about it, yet the guy in the middle makes more money per script than the retailer? Doesn't make sense to me, but they managed to do it. And, I think that, a company like Southern Scripts or somebody who's very, transparent in their modeling is probably a better solution. That's it.
And Rick, I loved your comments, and I think you also brought to light something that many people is a misnomer, is that the PBM truly never buys the actual drug. It's always the pharmacy, and all they're doing in the middle is negotiating those discounts. And and unfortunately, they've evolved to be able to I liked all your reference to inventing vehicles to um, work through that system to generate a good bit of revenue. But I agree, PBMs aren't really the buyers. They don't buy the drug from the wholesaler. That's the pharmacy.
Right.
Awesome, thank you. And I'm correct in saying, Rick, too, that their PBMs don't hold assets, they don't hold patents, they don't research, they don't manufacture. So we all know that. But so Isabella, I'll hand it over to you if you have a comment or question or both.
Yeah, well, first of all, thank you so much. This is very mind-blowing. I honestly, all my years with many PBMs, never really understood all the different levers that were in there that created revenue, and always was very happy when I got my discounts, which I now know are discounts and rebates, which were totally inflated. So it was mind-blowing. My big question is with Southern Scripts is, how do you show an employer the difference? Like, how could you break it down during a presentation of some sort? Because I'm sure that's the difficult part when you go talking to different companies. They're looking at their Express Scripts or CVS like they're the end all of everything, and you're coming in and saying, look, they're very different. How difficult is it to prove that out?
So the best way that I recommend anyone is, should they have access to their claims data, doing a repricing analysis. We do what it's a historical analysis, run the claims through the system as if we were processing, and see how the pricing applies. And certainly, we're a smaller PBM, but we are able to work closely with our pharmacy providers as partners and offer some good discounts, and they should be on par. And then when we give every bit of those discounts to the employers, they're exceeding many times the discounts of those that may take a percentage of that in the form of revenue. So we can reprice the claims and show the difference in the pricing. And along the same lines, the same thing with the rebates, quantify what the rebates would be, show those what that rebate yield would account to, and quantify that for them in that repricing analysis, and doing it with specificity, being able to show the actual claims and how they work. We further go along to demonstrate that to a client long term by giving them direct access to the system. They can see the exact price that the pharmacy has paid. That will line up exactly with the price that they are charged. With the rebate information, there's full disclosure as well on that, showing how the rebates apply to specific claims and specific drugs. So again, it is first doing that repricing exercise and with detail providing them a view into how this all works, and then ongoingly reassuring them and giving them that transparency, they can see it for themselves.
Great. Awesome. So thank you, Isabella, as always. And for the benefit of the folks on the line, Isabella said the same thing when she, kind of looked at what her carrier back in the day was or wasn't doing. So it's an equal opportunity shock when she retired and got access to some information that she might not have had before. Dr. Maya, you're up, and I just want to say, the reason that I'm here, the reason I think Isabella would say that she's here and is because of Dave Chase of the Health Rosetta. If anyone on the line has not heard of him or has not visited healthrosetta.org, I would encourage you. That's really how we heard about Southern Scripts. And Dr. Maya and I went down to Phoenix for a Health Rosetta Roadshow in June, and I mean, I've been corresponding with Dave, but Dr. Maya got to meet him in person and hear one of the programs. And what we both listened to that day was really data that I hadn't seen before. I know Dr. Maya hadn't seen before. Basically, in very briefly, it wasn't the doctors over the last, let's just say 20 years and say that costs have, gosh, well, they doubled over 10. So do the math. But over the last 10 to 20 years, the doctors simply weren't getting any richer. By adjusted for inflation, we haven't folks been paying doctors more. It's not them. And, the answer is hospital facilities. The hospital facilities are the ones getting much more of the money, but it's not been the doctors. And when you listen, when you see, as Leanne has pointed out, where there's waste in the system, and Rick rightly echoed that. Dr. Maya, what would you might have a comment and a question, I imagine, but this has got to be, you, just like Isabel said, your mind has to be exploding when you think of your colleagues. And I know you're not actively practicing clinically. You've moved on to some community health kinds of projects, but what do you think about what you just heard?
Well, thank you. And I first just want to say, Leanne, thank you for what you're doing in the world. I'm a physician, and yeah, my mind is blown with it. Every day that goes by, I've learned so much from everybody in the healthy retailers world, and what everybody's trying to do. But the fact that you would be out doing this is very meaningful to me. Your quote that you had, a big quote about how relatively few employers believe that the goals of their PBMs align with their goals for their employees' health. So if you think employers are suspicious of that, I can assure you, if there's any doubt, that doctors have absolutely no faith. We have completely lost faith in the system. And we've realized, yeah, that the money is not being funneled to physicians. Clearly, it's being funneled to big pharma and to healthcare organizations, which are not people who typically have spent 12 or 13 or 15 years in higher education understanding human medicine. So there's some there, but I don't think it's about the bitterness for most physicians. It's just about the bewilderment of it all. Like, what the heck? Why does it have to be like this? So I guess what I want to say or ask you is, I left clinical practice for many reasons, and much of it had to do with as my children were getting to the age where they were asking me questions about the world, my loss of faith in the system that I had spent until I was 31 becoming a part of. How can those most physicians in clinical practice would not have the wherewithal? They couldn't come and listen to your webinar in the middle of the day. They wouldn't be able to convince anyone at their hospital to do any differently, or in their organization or in their insurer plan. There are some physicians and some other people that have tried to emerge to help spread this education around. But how could your word be further spread to physicians who, after all, are at the end of the day that last channel of communication to patients, supposedly the people that all of this was created around a long time ago?
Wow, good stuff.
Sorry if that was a little
That's
you know, it is a big challenge, and I think, my story, I was a clinical pharmacist. I was residency trained shoulder to shoulder with the doctors at the University of Mississippi. I always felt I was going to be in that clinical realm, and I stumbled into the PBM world because I was working with employers on site as a clinical pharmacist, and realized that it didn't matter what I was doing to help that employee/patient and helping them coordinate with their doctor, helping them find lower cost options that they could afford. it didn't matter what I was doing. At the end of the day, many times the PBM held the key, and no matter what the work we had accomplished, it could be undone if we couldn't get that claim to get paid by the PBM. And it is frustrating, and it is what made me have to figure out how do I work with the PBM, the employer that I started with had at the time. But then it also opened my eyes that maybe there's a better way. I think it is hard to, how do we educate employers? It's a tough subject. How do we create physicians? They have a time limitation. How do we educate benefit consultants? And I would scratch the surface today in our 30 minutes about some of the tricks of the trade and some of the revenue vehicles that have been invented along the way. And they'll evolve, and there'll be more. And so it is challenging, but I think recalling the slide of the news articles, there's more and more call to action overall into finding transparency or disclosing and talking about the lack of transparency and what it does to the system. And I do think the momentum is shifting towards transparency and pass-through. So I think just hopefully the environment will continue to push towards that direction. So.
Well, thank you, Leanne. I would just, because most of the participants are benefits consultants, we thank each and every one of you for responding to the invitation. I kind of know it came out late. There's a kind of a story behind that, but we're so happy to have you on the call. My former colleagues at Aetna, like I did, went off to big consulting firms. I pulled back, not because I was really necessarily frustrated, but because for family reasons. But, you know, when I left, I was, and I know that everybody recognizes this, including Leanne, and I know Isabella would too, is that there was always a huge focus on utilization, on how many, you know, of our, you know, of a particular employee population was accessing, you know, this particular service under this diagnosis, and what was the cost, and what were the top five disease states. And that's all fine and good. Last November, I was in the Dallas-Fort Worth Business Group on Health Forum, and I cheered with a handful of other people when we said, okay, we got the utilization more or less down. Let's now get together and tackle the cost. And that's Dave Chase in a nutshell too. So that's just the 2 cents that I will pass on. And this is in that vein, in that spirit, that we got to look closer at, you know, I'll just say it, fake charge masters applying fake discounts to fake charge master made up prices. That's the frustrating part, of course, of the medical side, as we know. But we're going to work hard and do what we can to spread the word. And I think if we promote Southern Scripts and get Leanne better publicized than she already is, and that's my goal with press contacts and other plans, then hopefully Doc will, you know, we'll continue to put a smile on your face. You've added inspiration. Rick has, Isabella always has. So, but Leanne, thank you, and it really thanks to your whole family, to Steve, to your, you know, to the rest of your family. I think this is history being written, and I, for one, am very committed to advocating, in particular, for the modestly paid retail employee who hasn't gotten a raise. In fact, their net pay, total rewards, value of their total rewards, of course, has dropped because of the cost of healthcare. So, any final thoughts, Leanne?
Thank you.
Want to do some repricing. We want to send, if the consultants on the line would just like to email some repricing requests over so we can prove this out. How's that, Leanne? Did I do my job there?
we'll be ready and willing to take a look at those with them. But thank you all for having me and giving me the opportunity to share.
Thanks.
Thank you so much.
Take care, guys.
Thank you.